already 8. So I would like to welcome all the speakers, Dr. Anu Joseph, Dr. Sindhu S, and Dr. Manjima. So our session is on the topic anti-VEGF injections. Do we know enough? Our first presenter is Dr. Anu Joseph. She is a consultant at UVR department, Aravind Coimbatore, and her topic is anti-VEGF injections, a closer look.
A very good morning to all. A closer look of the anti-VEGF injections. It began as early as in 1948 when Michelson had hypothesized that ischemic retina released a factor X. It was in 1983 when Senger et al. From Boston identified the molecule and named it as the vascular permeability factor. Ferrara et al. In 1989 identified this molecule as vascular endothelial growth factor, a major regulator of angiogenesis. Further publication in 1989 of 2 back-to-back articles in Science began a new phase in this chronicle, the one that culminated in the development of the latest anti-angiogenic therapies. 1994, the American Journal of Ophthalmology published a key article showing that the hypoxic retina produces Vegf, suggesting the role of Vegf in ocular neovascularization. A study was conducted by lasering the non-human primate eyes, inducing neovascularization, which induced neovascularization of the iris. So this showed that a report of elevated levels of Vegf in the ocular fluids of patients with active neovascular ocular disease. So in this presentation, we go through the Vegf molecule, the Vegf receptor structure, how the Vegf signaling happens, and how is the anti-Vegf therapy useful. The vascular endothelial growth factor, also known as the vascular permeability factor, was originally described as endothelial cell-specific mitogen. Besides endothelial cells, it is being produced by other cell types, including tumor cells, macrophages, platelets, keratinocytes, and renal mesangial cells. So what is a vascular endothelial growth factor? It is basically a homodimeric glycoprotein which belongs to a family of secreted polypeptides. It is highly conserved receptor binding cystine knot structure. This shows the structure of a Vegf molecule. Which are the sources of Vegf molecule in the eye? In the retina, it is being produced by the Muller cells, the endothelial cells of the vessels or the supporting pericytes, the retinal pigment epithelial cells, and the retinal neurons and the astrocytes. And in the anterior segment, we have the non-pigmented ciliary epithelium, which is considered to be the reason for the ocular neovascularization of the iris. Vegf-A molecule is considered to be the founding member of the family, the single most important regulator of blood vessel formation, and is essential for embryonic vasculogenesis as well as angiogenesis. It is the key mediator of neovascularization in cancer as well as in other diseases. So how do the Vegf molecules exert their action? The hypoxic cells produce the upregulation of the Vegf molecules. There are 2 main mechanisms which happens. One is by the induction of angiogenesis, and secondly by the induction of an inflammatory process. The induction of hypoxia-inducible factor 1, and the consequent transcriptional activation of target genes. Increased Vegf transcription causes upregulation of angiogenesis and thereby restoring the oxygen supply and the nutrition supply of the hypoxic tissues. And how do the inflammatory process works? It acts by inducing the expression of vascular cell adhesion molecules, molecule 1, and enhancing the leukocyte recruitment and endothelial cell adhesion. This increases the blood-retinal barrier breakdown. So there are 2 basic mechanisms in how the Vegf molecule acts. One is by induction of angiogenesis, and secondly by induction of blood-retinal barrier breakdown. So just like Vegf-A being the prototypical member of the family of a related growth factors, it also includes placental growth factor, Vegf-B molecule, Vegf-C molecule, the Vegf-D molecule, also known as the force-induced growth factor, and Vegf-E, which is considered to be the viral factor. And another interesting variant of Vegf is also expressed in the venom of habu snake. It's a variety of pit viper native to Japan. Vegf molecules are now mediated by a family of protein tyrosine kinase receptors. So it has basically three structural importance. One is three parts. One is an extracellular portion consisting of 7 immunoglobulin-like domains. Secondly, you have a single transmembrane spanning region. And thirdly, there is an intracellular portion consisting of a split tyrosine kinase domains, which is of most important part of the VEGF receptor. So where are the VEGF receptors located? They are in the endothelial cells, retinal pigment epithelial cells, as well as in the bone marrow derived epithelial cells, which is of importance in cancer patients. So what is the difference between vasculogenesis and angiogenesis? Vasculogenesis, it is the formation of new blood vessels from angioblast. Angioblasts are the endothelial precursor cells which differentiate into endothelial cells. And what is angiogenesis? That is the growth of new blood vessels from already existing blood vessels. That is more of a pathological change. So this flowchart shows which all VEGF molecules act in the corresponding VEGF receptors. Here we can see that the name VEGF corresponds to VEGF A molecule. It acts via the VEGF receptor 1 and the VEGF receptor 2. And the action mediated via the VEGF receptor 1 is mainly vascular organization. That is the expression of matrix proteases and thereby stabilizing the vessels. VEGF receptor 2 mediates mainly angiogenesis, that is the proliferation of the new vessels. The VEGF C and D molecules act via the VEGF receptor 2 and VEGF receptor 3, and the action mediated mostly through the VEGF receptor 3 is lymphangiogenesis. So these are the main receptors which promote the action of the VEGF molecules. And certain subtypes of VEGF A are VEGF 165, which is most important, and VEGF 145. And they tend to act via the co-receptors, which have the efficacy only half of that of the main VEGF receptors. They are called neuropilin receptors. So they promote angiogenesis, as we have seen, and vascular permeability, cell migration, and gene expression. And Lee et al. Had proved that there is an autocrine loop for VEGF A molecule, which contributes mainly to the endothelial functions. So when VEGF molecule binds to the VEGF receptors, it initiates a cascade of events. There are two main mechanisms. One is by activation of a phospholipase and phosphokinase pathway, which is being which is being the main mechanism for most of the anti-VEGF drugs. And there is another AKT pathway. AKT pathway is the main mode of action of the tyrosine kinase inhibitor drugs. So it causes a balance of the pro and the anti-angiogenic signals, resulting in sprouting of the new blood vessels, cell proliferation, and cell migration. So when there is a VEGF receptor signaling, VEGF receptor 1 has a higher affinity for VEGF A molecules. And the tyrosine kinase activity is approximately 10-fold weaker than that of a VEGF receptor 2. The major pro-angiogenic signal is believed to be generated from the ligand-activated VEGF receptor 2. There is a negative regulatory role for VEGF receptor 1 in angiogenesis at early embryogenesis. So the anti-VEGF antibodies, the efficacy is basically in terms of their vascular normalization. Once an anti-VEGF antibody is proved to be effective, it makes the abnormal vessels well covered with pericytes and thereby lowering the vascular permeability. The anti-VEGF receptor drugs have been classified into two main groups. One is of importance to the ophthalmologist, as we all know, the anti-VEGF antibodies. And secondly, the tyrosine kinase inhibitors like imatinib, sunitinib, which are of importance to the oncologist. And certain other groups include the VEGF trap molecules, soluble VEGF receptor peptide vaccines, and antiplatelet growth factor antibodies. And these are, most of them have come into market, like VEGF trap is the aflibercept, and rest are undergoing preclinical and the clinical trials. So it is that the area of ischemic retina, which characterize a number of ocular pathologies, most notably in ROP and diabetic retinopathy, which increase the need for the development of the anti-angiogenic therapies. And the first treatment developed using this VEGF neutralizing strategy was bevacizumab for systemic use, mainly for the purpose of cancer treatment. And secondly, of importance to the ophthalmologist is the neovascular AMD. The first drug approved by the FDA was pegaptinib, an RNA aptamer that binds and neutralizes VEGF 165. And the drugs will be dealt in detail in the upcoming presentations. So after 6 full decades, Michelson proposed the existence of factor X molecule. We are right now standing in an era of anti-VEGF molecules which have been adopted and proven to be valuable in the treatment of a lot of blinding eye conditions. Thank you.
Thank you, Anu, for that detailed presentation. Next, I call upon Dr. Sindhu S. To talk on the topic anti-VEGF injections, what's been there and what's new.
A very good morning to all of you. So, first of all, let me say there is no financial interest in this presentation. So, coming to the history, in 2004, the first anti-VEGF, that is pegaptanib, was approved by FDA for using for neovascular age-related macular degeneration. Bevacizumab came in the same year, but it is an off-label use. It was initially invented for the purpose of treatment of colorectal cancer. In 2006, ranibizumab, that is the Lucentis, was approved for neovascular AMD. 2011 came the aflibercept or Eylea, which was approved for neovascular AMD. 2019 was the brolucizumab for neovascular AMD. 2022 came the faricimab for neovascular AMD and DME. And 2023 we got the 8 mg aflibercept, that is Eylea HD for neovascular AMD and DME. So as Dr. Anu said, the first with FDA, first drug was pegaptanib or Macugen. It is an RNA aptamer oligonucleotide, but it blocks only a single VEGF isoform, that is 165. It was available as a pre-filled syringe of 0.3 milligram. And the VEGF inhibition study in ocular neovascularization trial showed that it was effective in all types of neovascular AMD, and the patients in 2-year results showed they continued to have a sustainable visual benefit with 0.3 milligram dose and adequate safety during 2 years of therapy. However, it was discontinued because it had exclusive inhibition of VEGF-A 165 isoform. Then came the bevacizumab. Bevacizumab is a full-length recombinant humanized monoclonal antibody, and it is active against all isoforms of VEGF-A. But for ophthalmology, it is an off-label use, and it will be there. We'll have medico-legal issues if any complication like end-off comes while using this drug. But however, this drug has got a long history of safety and potency, and it is available in 100 milligram and 400 milligram vials, and it has to be aliquoted in small syringes, and the dose to be given is 1.25 milligram in 0.05 ml. Then there is convincing data, though it is an off-label drug, there are data, that is the CAT trial, which showed when it is compared with ranibizumab, that the visual acuity was not statistically significant difference between these two drugs, and both the monthly and PRN dosing showed a same result with both the drugs. And regarding the safety, the adverse effects like the systemic adverse effects and the serious side effects and hospitalization events were same in both the groups. So at 1 and 2 year follow-up, the CAT trial showed that bevacizumab was equally effective as its congener. Then came the EVAN trial, which also compared the same ranibizumab and bevacizumab for wet AMD and the same monthly and PRN regimes, and showed that both were equally effective, and it was comparatively cost effective when compared to ranibizumab. Then the PACOR study, which had studied mainly in central involving DME and PDR, the 5-year result showed that the visual acuity actually at 5 years there was not much of gain, but initial years there was gain, mainly because it was due to the under treatment and presence of persistent SRF. However, in PDR with previous PRP, there was marked regression of neovascularization. Then the CVOS study, which also showed that bevacizumab was equally effective at substantial gains in visual acuity at the end. And similarly, the adverse effects was common for almost all the anti-VEGF transient IOP rise, which was normalized without any intervention. And the incidence of sterile endophthalmitis and bacterial endophthalmitis was almost same in both the groups. Then ranibizumab is a recombinant humanized monoclonal antibody which binds to all isoforms of VEGF-A. And the structure of the ranibizumab is smaller, hence it is better penetration. And in 2006, it was FDA approved and it was demonstrated by the Marina and Anchor trial. So you can look into the molecule, you can see the structure of the ranibizumab when compared to the bevacizumab. The smaller size allows better penetration because this does not have the FC domain. And the two ranibizumab molecule binds to each VEGF dimer. And it has a higher stability and greater molecular affinity. The approved dose is 0.3 milligram for diabetic retinopathy with or without DME and diabetic macular edema. And for CNVMs and macular edema due to vein occlusions, it is 0.5 mg. The half-life is 3 days, but for the bevacizumab, it was more 20 days. Then came the aflibercept. It is a 115K Dalton fusion protein. Here the IgG backbone is fused to the extracellular VEGF receptor sequence of human VEGF receptor 1 and 2. So it's basically a VEGF trap. So instead of binding to the VEGF receptor, the VEGF molecules binds to aflibercept. So the recommended dose is 2 mg in 0.05 ml and seems similar. It can be given for neovascular AMD, macular edema following RVO, DME and DR with DME and myopic CNVM. Then came the ILIA HD, that is 8 mg aflibercept, and several studies like the Pulsar and Photon trials showed similar visual gains, anatomic improvement, safety profile and durability. The main advantage of the ILIA HD was that after the initial loading dose, the need for repeat injections was less. That is 2 to 4 monthly only for wet AMD and DMB and 2 to 3 months for DR. This was because of its longer durability. Then Civ aflibercept or Zaltrap. It was a same protein as aflibercept, and similarly this was just like a bevacizumab given for colorectal cancer. It is an off-label drug and it is got high osmolarity, but it was a cheaper alternative. It is recommended dose is either 1.25 milligram or 2 milligram. There is no major ocular or systemic side effects, but there is lack of large randomized control trial for using Zaltrap. Then brolucizumab, it is a humanized monoclonal single chain fragment with higher binding affinity, and it inhibits VEGF-A, neutralizes, so it doesn't allow VEGF-A to bind its receptor 1 and 2. And the recommended doses by Hawk and Harrier studies is the 6 milligram per 0.05 ml, and it was found that brolucizumab was non-inferior to aflibercept in visual outcome, and the anatomical outcomes was also favorable with brolucizumab. And some side adverse effects was the retinal vasculitis, retinal arterial occlusions, intraocular inflammation, though it is mild and self-limited. Then faricimab, the recent one, the humanized monoclonal antibody, and this has a dual mechanism, that is, it not only binds to VEGF-A but also to angiotensin 2. So it has got an extended durability. And the recommended doses by the different trials, that is Yosemite, Rhine, Stairway, Barton and Comino, is 6 milligram per 0.05 ml. And 8 to 10% there is presence of antifaricimab antibody, and there is no safety and efficacy in pregnancy, and similar to the brolucizumab, retinal vasculitis and vascular occlusions can rarely occur. Then came the biosimilars. Biosimilar is something similar to the reference drug. It has somewhat same effect, but they do not have the same identical ingredient. They are not small like biologics, they are large complex molecules. They identify the gene and then they clone into a vector, and cell cultivation is used to form a biosimilar. However, it is less lengthy and less costly process for development. And in biosimilars, it is the live cell. It is not an exact copy. You have to assess the stability, immunogenicity, and excipients are allowed. And then, since it is less costly, it is more cost effective and patients can utilize it. So you can see the difference that for a biologic to be approved, it is a long clinical study and everything you have to go through. But for a biosimilar, there is not much of clinical studies needed for that. So it is same with the respect to the safety and potency, it is almost same with that of the biologic. So the bevacizumab biosimilar was Mvasi, which was used as off-label for wet AMD, and it was shown that it was a viable and cost-effective therapy when compared to its original molecule. Then came the Zybe. Zybe also showed that in the macular edema due to retinal disease, the Zybe was really effective in terms of safety and potency. Then ranibizumab biosimilars we have lot, and the first which came into India which was approved was rasumab. The recommended dose is 0.5 milligram per 0.05 ml. And these are different other ranibizumab biosimilars in the market. And in pipeline are the aflibercept biosimilars like Yesafil, Opuvis, Encivo, Asantiv, and Pavblu. So to conclude, anti-VEGF therapy has become one of the most frequent treatment modalities in ophthalmology, and the usage has become wider, and investigations are going on for new drugs which act for a long time and new modes of delivery as well. Thank you.
Thank you, Dr. Sindhu, for taking us through the various anti-VEGF molecules. And Dr. Sindhu works as a consultant in the vitreoretinal services of Little Flower Hospital, Angamali. Next, I invite Dr. Akshaya of Sunrise Eye Hospital, medical retina consultant, to talk on the art of injecting anti-VEGF injections.
Thank you, Anu. Good morning to all. So as we have gone through the chemical composition and the different types of anti-VEGF injections in detail, now my task is to describe the right technique of giving intravitreal injections. So as we all know, intravitreal injections, they are known for their quick and targeted therapy. They allow you to achieve therapeutic levels locally, causing minimal side effects to the patient. And they have become almost become an indispensable part in the lives of retina specialists. They are so widely used these days for the management of diabetic macular edema, in CMEs involved in vein occlusions, AMD, PCV, in the treatment of neovascular glaucoma and ROP. And we have a wide range of injections available in the market, and with the influx of biosimilars, they have become so much more affordable to the patient, and because of which the number of injections being given have increased dramatically in the past few years. So we all know that giving intravitreal injection, it is an easy breezy job. It does not require much of a skill to give an intravitreal injection. But then there are a few things which needs to be emphasized, which have to be kept in mind before, during, and after giving intravitreal injection. And first and foremost is getting an informed consent signed by the patient and the bystander. Even though it's just an injection, we need to get an informed consent, which should include the disease for which the injection is being given, the name of the injection, and the possible complications that could occur following an injection. Secondly, counseling of the patient. Very important to let the patient know the nature of the disease in the eye, why they are getting the injection, what to expect from the injection, and the reality that they may need multiple injections in the future, and also they may have to switch to a different drug during the course of treatment. Because you don't want the patient to come back to you saying, doctor, I got one injection, I already got 2 injections, but I still have the disease in the eye. So in most of the diseases, we all know the aim might not be to get a perfect 6x6 vision. It might be just to maintain a reasonable, decent vision in the eye. Third point is topical antibiotic. It is again controversial. There is no foolproof evidence that giving intravitreal antibiotics prior to injection can prevent endophthalmitis, but I think most of the doctors prefer to give topical antibiotics at least 3 days prior to giving an injection. And then every step during while giving injection should be done under thorough aseptic precautions. And any active lid infections should be looked out for and should be treated before giving injections. Any hordeolums or blepharitis, everything should be treated before giving intravitreal injection, because these could be a strong source of infection following the injection. Now, preparation of the eye. Instillation of 5% povidone iodine in the conjunctival sac is an accepted universal practice, and it has been strongly recommended for the prevention of endophthalmitis following injection. So in our setup, after instilling povidone iodine, we also give a nice lid scrub with a cotton bud soaked in 5% povidone iodine. Both the upper and lower eyelids are scrubbed nicely. And to give an injection, all we need is a pair of cotton buds, a caliper, a speculum, then an insulin syringe, a 30 gauge needle, and a longer needle to withdraw the drug into the syringe. While you withdraw also, we should make sure that everything is done under aseptic precautions. You have to draw 0.05 cc, a little more extra you can draw, because there some amount of drug can go into the subconjunctival space as you withdraw the needle. Now the technique. So the quadrant that you choose for the injection is totally up to the surgeon. Whichever quadrant you are comfortable with, you can pick. So I am a left-handed person, so I prefer supratemporal quadrant for the left eye and supranasal for the right eye. But then most of the people, I think they prefer inferior quadrants, because the patient always has a tendency to roll up their eyes, to squeeze their eyes, so it's more comfortable for them to look up rather than look down. But then one small advantage of giving a superior, choosing a superior site is that small subconjunctival hemorrhages that could commonly occur could be masked by the upper lid. So you can save the patient getting worried the next day seeing that bright red spot in the eye. Otherwise, it's totally up to the surgeon. Whichever quadrant they want, they can choose. And it's always better to get the eyes dilated before the injection so that you can see the needle as it enters into the globe. Now you take the measurements using a caliper. Measurements are taken from the limbus, 3.5 mm for the pseudophakic eye and 4 mm from the limbus for the phakic eye. So once you take the measurement, using a cotton bud soaked in paracaine, you can gently retract the conjunctiva at the site of injection to avoid any vessel if present. And then with your dominant hand, you go perpendicular to the globe, directed to the center of the globe. It's important that you go perpendicular to the globe, because if you tilt anteriorly, there is a high chance that you touch the posterior capsule. And then once you inject with your dominant hand, you slowly withdraw the needle and then immediately keep a cotton bud over the site of injection for a few seconds, and then that's it. You can put a drop of topical antibiotic following the injection. So any procedure comes with its own set of complications, and anti-VEGF injections are even they come with their set of complications. So they do have their drug-related and procedure-related complications. Drug-related complications, there is a very rare chance of thromboembolic events, stroke, myocardial infarction, renal diseases following anti-VEGF injections. And procedure-related complication, as I said, the most common is development of subconjunctival hemorrhage. Nothing to worry for the doctor, but scary for the patient. The patient will get obviously scared seeing that bright red spots in the eye, but then all you have to do is tell the patient that it's going to fade away in a few days. The second complication that could occur is development of corneal epithelial defect. This usually occurs when the patient, under the effect of anesthesia, they tend to open their eyes under the iPad, and then the iPad rubs over the cornea. So if the patient complains of pain the next day, day one following the injection, most probably it's going to be due to an epithelial defect. So again, it can be treated easily with copious lubricants. It's going to heal in 2 or 3 days. Third complication is development of cataract. As I said, it is because of the wrong technique of injection. If you tend to tilt the needle anteriorly, there is a high chance you touch the posterior capsule, and it can result in development of cataract. And there could also be an acute rise in IOP following injection, but then usually it lasts for only few hours. So it's always advisable to check the IOP following the injection and treat accordingly. And finally, the most dreaded complication, which nobody wants, is endophthalmitis. Although the incidence is very low, 0.019 to 1.6%. If the patient complains of pain, redness, photophobia, lid edema, following injection, usually they present 2 to 3 days following the injection, then that should raise an alarm. It is an emergency, and definitely it has to be referred to a vitreoretinal surgeon for to treat accordingly. So that's it. Thank you all for your patient listening.
Thank you, Akshay. That was a very informative talk. And 1 second, I have a question for Akshay. Is there any preference to give the steroid injections regarding the quadrant to be chosen?
Steroid injection also, when I give Ozurdex and all, I prefer supratemporal for the left eye and supranasal for the right eye. Then I don't I have never given any special importance to steroid injections. I usually choose the same site which I choose for anti-VEGF.
Okay, thank you.
Do you give bevacizumab now also?
Bevacizumab, yeah, we do give, because we in our place, not all patients go for biosimilars also. So there are few patients who do not afford biosimilars also. So then we do give, yeah, we do
So
give
you give
bevacizumab.
with
We
the
still give.
Consent, you take a separate consent, like
Yeah,
this is
and we
off-label.
mentioned that, yeah, it
It's
is
an
off that
off-label.
we mentioned, yeah.
Thank you.
Next, I invite Dr. Manjima Mohan, working in Iris Eye Hospital, Kannur, for speaking on anti-VEGF injections, when, why, and what to choose.
Good morning, everyone. I'm going to talk about anti-VEGF injection. That is when, why, and what to choose. So, already my co-presenters have already talked about more about VEGF molecule, what they are doing. So basically, VEGF is the one that promotes vascular permeability, that increases the vasodilatation, and it basically increases the angiogenesis. So just by blocking VEGF, we can reverse this process, and thus by limit the disease. So when to give the anti-VEGF injection? We know in diabetic retinopathy, the most common cause for defective vision is diabetic macular edema. When the diabetic macular edema is involving the center, we have to give a anti-VEGF as the first line. And when the macular edema is due to a vein occlusion, in central retinal vein occlusion or in branch retinal vein occlusion, we need to give a anti-VEGF. Then comes exudative or wet ARMD. If the patient comes with an active disease, that is a subretinal hemorrhage, a fluid at the macula, again we need to give anti-VEGF. Then in preterm babies, if there is a history of oxygen therapy and all, there is a chance of ROP that also needs anti-VEGF injection. And another indication is some VR surgeons prefer to give anti-VEGF before vitrectomy, just to reduce the bleeding, so that operating time is reduced and risk of iatrogenic breaks are reduced. And also in neovascular glaucoma, just before IOP lowering procedures, glaucoma surgeons also prefer to give anti-VEGF. So in the market, we have many options available now. I'm just talking about a few agents which is available in the market currently we are using. So it all started with bevacizumab, and then came ranibizumab, then we had aflibercept, then brolucizumab, and recent one faricimab, and we have biosimilars as well. So what are the factors to consider when we give an anti-VEGF? For me, the first and foremost important thing is the safety. A drug should be equally efficacious as well as safe. We cannot give a drug which is not safe, but it should be balanced between both of them. See, in the olden generation, in the ARMD cases, we used to tell the patient there is no treatment before the anti-VEGF era, and then later laser came, and it was very efficacious. We can treat the lesion, but patient will lose the vision. So a treatment should be like, it should be safe as well as efficacious. So when Marina and Anchor trials, after Marina and Anchor trials, when VEGF came into play, so that was a revolutionized the treatment in neovascular AMD, where we can preserve the vision. So the next point is drying effect. So when the word drying effect comes, the first thing coming to my mind is the newer agents, that is brolucizumab and faricimab, which is having a better drying effect than the conventional agents. So if the drying effect is more, the frequency of injection, that is injection interval, will be less, that is there. And the response to previous treatment, that is also an important factor. So if you treat a disease with one injection and the patient is completely stabilized, and after some point of time if the disease recurs, we can use the same agent which was efficacious for that patient. We don't need to switch when the recurrence comes. That is another point. And the regimen we are using, that is also an important thing. Being a developing country, most of us are following PRN base only. There is a treat and extend regimen also. Studies are using a treat and extend, but in the real world, it is practically it is difficult in a developing country like India. And the most important factor, what I consider, is the cost. Even if I tell, if a PCV patient comes, if I want to give an aflibercept, but if the patient cannot afford, obviously we have to go for the low-cost agents. So cost is the most important thing when we consider an anti-VEGF agent, because we have to consider that patient have to come to the hospital, the transportation, and the bystander, and their daily wage loss. So everything have to be in mind when we advise an anti-VEGF agent. And all the trials, we know all the agents have proven their efficacy and safety. And when we give an injection, we have to look at the disease, which disease we are treating. So in DME, we know not only the VEGF, some other molecule like inflammatory molecules, inflammatory mediators, that are also playing an important role. So we need to keep in mind that also. So only anti-VEGF, it is not the treatment. We have to go for other molecules as well. Then in wet AMD, as I already told, Marina and Anchor, these were the trials that revolutionized the treatment in wet AMD. Then we have the newer molecules as well, aflibercept, brolucizumab, and faricimab. These newer molecules, they are having a longer duration of action because the drying effect is more compared to the conventional agents. And when we come to the meta-analysis of neovascular AMD, when they compared brolucizumab, aflibercept, and ranibizumab, they all have similar visual acuity gains as monotherapy. All were having similar visual acuity gains. And also, when we look at the safety profile, they all were having similar discontinuation rates as well. Discontinuation rates means if there is a serious or non-serious ocular side effects, we will discontinue the drug. So all were having similar discontinuation rates, but the only striking thing was brolucizumab was having a better drying, that is central macular thickness reduction was superior for brolucizumab. It was around 39 microns in the first year and 35 microns in the second year. But when we closely look, we don't know actually whether this number is actually important when we look at the long term, because we don't know, we don't have the 3-year and 5-year data. And what we assume is, since it is having a better drying effect, it may be able to sustain the visual acuity gains in the long term as well. And when we look at the number of injections, the mean number of injections in the second year after PRN dosage for aflibercept it was 6.5, brolucizumab it was 5.7, and for ranibizumab it was almost a double, that is 11.5. So that is also there. So patient need to come more often with the conventional agents. The newer agents having a longer duration of action, but we don't have that much evidence to tell about the safety. And that was about AMD. And the DME also, the meta-analysis is showing equal comparable visual acuity gains in all the agents. Only in the first year, the aflibercept and brolucizumab was having an extra edge over ranibizumab, but when we look at the second year, all the agents were having comparable visual acuity gains. So that is why I'm telling we have to look at the long-term results than the immediate effect. So when we talk about the safety profile, we know when bevacizumab was given, initially there were reports of cluster endophthalmitis. Then we had ranibizumab, and biosimilars also came. And ranibizumab was having 1.5% of inflammation in ANCHOR and MARINA trials, but there was no vasculitis. Aflibercept, it was 1.1. So basically, ranibizumab and aflibercept, both of them having an extra edge over the newer molecule in terms of side effects. So brolucizumab was having 4.6% of intraocular inflammation in Hawk and Harrier study, and vascular occlusion rate of 2.1%. But so the brolucizumab side effect is real, it is there, and the better thing or the good thing about this brolucizumab side effect is it is treatable. So the patients are treated with topical steroids and oral steroids, and their condition improved. So that is also there. So when we consider these kind of agents, we have to select the patient properly. And we have Indian studies as well, where they compared newer agents with the brolucizumab with the aflibercept in RR Hospital, New Delhi. They conducted a study. It was a RCT. And they also found comparative visual acuity gains, but they were also telling about the drying effect of brolucizumab, which is more, especially in the subretinal compartment. So the inter-injection interval was more with the brolucizumab group. And another study, Braille study, again from in Indian patients, it is also shown efficacy of brolucizumab. And after 126 injections, there were no case of inflammation in patients. So basically, what we see from Western population, the side effect is more with the Western population than the Indian patients. And the newer molecule faricimab, it is a dual antibody that is blocking VEGF as well as angiopoietin 2. And in the TENIA and LESSON trial studied for neovascular AMD, that also showed that brolucizumab is not inferior to aflibercept. And in DME also, Yosmet and Ryan studies, it proven the same non-inferiority of brolucizumab with aflibercept. But the striking thing there also is, after the loading dose, the maintenance phase, aflibercept was given 8 weekly, but we can extend faricimab a little more. That is something around 12 to 16 weeks in patients. So in conclusion, there is no one anti-VEGF for all disease. We have to select according to the patient. It is a tailored approach always. The conventional agents, ranibizumab and aflibercept, it's always efficacious, and it is having a cutting edge over newer agents because of the lesser side effect profile. But newer agents, brolucizumab and faricimab, both are having a promising results because of the better drying effect and longer inter-injection interval. So we have to consider all the factors when we choose an anti-VEGF. So patient selection is important. We don't want to take a chance in a one-eyed patient, so we don't want to give brolucizumab in a one-eyed patient. And patients who are prone for inflammation, we don't want to give brolucizumab in those kind of patients. And patient education is also very important when we give anti-VEGF injection. So cost is one of the important factor in deciding which anti-VEGF to choose. Thank you.
Thank you, Manjima, for that informative talk. I would like to ask Dr. Sindhu, ma'am, do you have any experience with faricimab? Have you used it?
We have used it in wet ARMD, but ideally, actually, we have given only 2 doses. So yet to say the result. Like mainly this faricimab and all, after the initial loading dose only you can know like how frequent we have to repeat. Because they have told specifically that the weeks actually told. Now, after the loading dose, maybe you can wait for at least 2 to 3 months for a repeat injection. But we have not reached to that stage. Just we have finished 2 doses for one patient with wet AMD. So yet to know whether that is coming true.
Any other questions from the audience?
The patient was going abroad, so she was willing to come monthly. She can't come frequently. So she was given an option like this drug, like after the loading dose, you have a chance that you can come less later, like you can come locally because she has access to take OCTs there. So she can send it through WhatsApp and only if needed she can come. So we told that the possibility is like after the 3 injections, maybe you can extend your follow up. So she had a financial no problem, so she opted for this. Vabysmo. Like after the loading dose, if there is the subretinal fluid, intraretinal fluid, the treatment is going on. So monthly, actually I make the patient come every month till he becomes dry. And that treat and extend actually I have not done so far. I usually follow the PRN. Yeah, PRN only. Like every month the visit is there. Every month the visit I make because like it's to treat and for 2 months not to see the patient in one night it's difficult for me. So I usually call the patient every month. And now we have got that Octa also, so we can monitor the neovascularization as well. Treat and expend any.
Even I follow PRN and I don't even dare to explain to the patient also. But then, as you said, this medico-legal aspect, if we look, we have to explain to the patient regarding, at least give them an option of treat and extend. Yeah.
I have usually a trend to give both the Oracort and Osurdex inferiorly only. Maybe mostly because of the similar experience that the drug is floating in front of the eye. So usually the infronase like inferior anyways. Like if it is a PRP means first a nasal is given, then 2 weeks. 2 weeks. 2 weeks. Then those patients, 1 week I have started. Like those patients who have to go abroad, within 1 month they will finish the PRP, one injection result we can know. If needed, one more injection he can take and go.
So I think we'll wind up this session. Thank you all for your patient listening. Thank you so much.